So you should know the anatomy of the urinary system, the gross anatomy as it sits in the abdomen. Know the location of the kidneys, which one sits a little higher, which one sits a little lower. Again, your kidneys, ureter, urinary bladder, and kind of where they sit in relation to the other organs of the abdomen. Again, just another view. Again, the anterior view on the left there shows that the right kidney sits a little bit lower. And again, the posterior view, you can see that breakage of the floating ribs can pose damage to the kidneys as well due to their location. Inferior view of a transverse section through the abdomen at the mid-level of the kidneys. Again, take note, the blue line that you see there is the parietal peritoneum. The kidneys, again, are retroperitoneal. Remember, they're behind the peritoneum. They're not within the peritoneal cavity, so there's no visceral peritoneum on the surface of the kidneys like there would be on the small intestines, stomach, things of that nature. Again, the kidneys do have a kind of a renal fascia and fat pad around them, protecting them, but you should kind of know, their location within the abdomen. Okay, so the next two slides are coronal or frontal section views of the kidneys. This one is a little more cleaned up, and you can see the what they refer to as the pyramids of the medulla a little more clearly in the diagram on the right there. Cortex, again, cortex, cork, bark, the outer portion of something. The cortex is the outer portion of the kidney. The medulla is the deeper portion. And again, the medulla, the tissue of the medulla is arranged in little pyramid-like fashion, and there are columns of cortical tissue that extend between those medullary pyramids. The medullary pyramids empty into a minor calyx. Calyx, again, just being a connective tissue membrane that surrounds and encapsulates and separates this newly formed urine from the rest of the abdomen. The minor calyx is continuous with the major calyx, which is continuous with the pelvis of the renal pelvis, and then continuous with the ureter that channels the urine into the urinary bladder. The renal sinuses are, again, just openings continuous with the outside of the kidney as well, usually packed with fat, but in these dissections all the fat is gone. The hilum of the kidney, just like the lung, would be that indentation where the ureter leaves and the blood vessels enter and leave as well. So you should know all the anatomy that you see on this page as well as the following. So on this page, the renal pyramids, again, on the diagram, are not quite as pyramidal, but you get a little more view of the blood flow and some of the things like that. Again, the medulla is really pockets of tissue, but you would call all of that deeper tissue within the kidney the medulla. Again, the flow of filtrate through the nephron and urine through the kidney is something you should know for this practical, but when you kind of come back to this diagram as well as the one before, you should know the flow of filtrate as well as urine through the nephron of the kidney. Okay, so on this slide you see two different types of nephrons. You have your juxtamedullary nephron on the left there, which is by its name, closer to the medulla. Something is juxtaposed, is situated next to something, so it is next to medulla, it sits at the boundary of the medulla, and you see the boundary of the medulla there is formed by the arcuate artery and vein pair. That is usually the defining line between the medulla and the cortex, is that arcuate artery. So deep to that pair would be the medulla, and as you see there, the juxtamedullary nephron has this long loop of Henle, or nephron loop, that dives deep into the medulla. This allows for formation of very concentrated urine, basically. And it also has a structure known as the vasa recta associated with the juxtamedullary nephron. So the cortical nephron, located more within the cortex, has got a very short loop of Henle that only dives so deep into the medulla, not that deep at all, and most of your urine is produced by this cortical nephron type. It doesn't make quite as concentrated as urine as the juxtamedullary, and this has no vasa recta associated with it, but it does have more paratubular capillaries, as you see on this diagram as well. The other thing to kind of take note on this diagram, and we'll talk about blood vessels in the next slide or two, if you again look at your arcuate artery and vein, and over there on the right, you see your cortical radiate artery and your cortical radiate vein. Again, that cortical radiate is a name that varies depending on different sources that you look at. So we'll look at both here in a minute. As well as this diagram just has a good couple of representations of nephrons with your proximal convoluted tubule, descending and ascending limbs of the loop of Henle, and your distal convoluted tubule. So you should know the flow of blood through the kidney, starting with the renal artery, branches into a segmental artery, which branches into an interlobar artery that surrounds each renal medullary pyramid, forming the boundary between the cortex and the medulla. You have the arcuate artery, and the next branch off the arcuate artery is either the interlobular, or, as you saw on the previous slide, the cortical radiate artery. The next branch from the interlobular or cortical radiate artery is the afferent arteriole, which flows into the glomerulus. Blood flows out of the glomerulus to the efferent arteriole and into either the paratubular capillary set, if you're talking about a kind of a cortical nephron, or into the vasa recta if you've got something more of a juxtamedullary nephron. From those two back into the arcuate vein, or the interlobular / cortical radiate vein. Sometimes anastomosis or branch into both there. Back through the arcuate vein, through the interlobar vein, and again there is no segmental vein, so from the interlobar vein directly into the renal vein, and then out through the kidney. So you should know the flow of blood through the kidney, and you'll see that on the next slide as well. So again, blood flowing into the kidney through the renal artery. You have a segmental artery, interlobar artery, arcuate artery, and then branches into, again, this one refers to the cortical radiate artery, or interlobular, either or. Again, into the afferent arteriole, the glomerulus, out through the efferent arteriole, and into either the vasa recta or paratubular capillaries, back into the cortical radiate / interlobular vein, or arcuate vein, into the interlobar vein. Again, there is no segmental vein, and back out through the renal vein into the inferior vena cava. So again, just be able to fill in the blanks if I were to give you a diagram like this of flow of blood through the kidney. So some differences between male and female urinary structures. Female, you see there on the left, the urethra is much shorter, and the female is also missing an internal urethral sphincter muscle that they do not have, that is found within the male. The male has both an external and internal urethral sphincter. Female only has the external urethral sphincter as the urethra passes through the urogenital diaphragm. Structures again to know: the trigone is the triangular area between the openings of the ureters into the bladder, as well as the opening of the urethra out of the bladder. That triangular area stretches much less than the rest of the urinary bladder. What you're seeing here on the left is a glomerulus. If you were to fill the capillaries with a solid and then erode everything else around them, this is what you would find yourself with, something like that. And then, of course, you're looking at a dyed picture of the kidneys, ureters, and bladder on the right. So you should understand filtration that occurs at the glomerular capsule or Bowman's capsule, and kind of the directions that these pressures want to push water into, because the direction can change if our variables change. So the first one you see there, number one, glomerular capillary pressure, is basically blood pressure. Okay, that is the pressure generated by our heart when it contracts and pushes blood through our vessels. All right, by the time you are at a very small vessel in the glomerulus, that blood pressure is about 50 millimeters of mercury, and that pushes in the direction towards formation of filtrate. All right, that pushes fluid out of the capillaries and out of the capillaries of the glomerulus and into the Bowman's capsule. So the next pressure you see is capsular hydrostatic pressure. That is simply the pressure of the fluid already present in the Bowman's capsule, the filtrate that has already moved across the capillary into the capsule and just hasn't moved along yet. So it's just physical pressure of fluid that's already present, and that pushes opposite the direction of filtrate production. The third, number three, is blood colloid osmotic pressure. That is just like it says, colloid pressure, and that is a pressure due to the presence of large proteins that are trapped within the blood vessels. These large proteins do not pass through the small fenestrations and holes and capillaries, and they exert an osmotic pressure. And if you remember, osmosis draws water toward a higher solute concentration. So in this example, there is more solute within the blood than there is within the filtrate. So that wants to draw water towards the blood. Water wants to get drawn back into the capillaries. Now, this normally happens within the tissues of the body, but this is an area where we want to force filtration to occur. So if you add up the pressures and again subtract the ones that are in a direction opposing the larger pressure, you get a gross pressure towards filtration production of 10 millimeters of mercury. All right, so you've got 50 millimeters from blood pressure towards filtration production. You have an anti-pressure of 10 millimeters of mercury from just the presence of the fluid, and you have an anti-pressure of 30 millimeters of mercury from the presence of the colloids within the blood, the trapped proteins, and etc. So you subtract 40 from 50, and you only have a net filtration pressure of 10 millimeters of mercury. So what that tells you is, with enough back pressure, if the blood pressure were to drop enough, and say the blood pressure, glomerular capillary pressure were only 40 millimeters of mercury, the capsular hydrostatic pressure and blood colloid osmotic pressure, those are not going to change. So 40 minus 40 would give you 0 net filtrate production. So if blood pressure drops dramatically, filtrate production within the kidney will quickly cease. Okay, so have an understanding for those pressures and kind of how they work and what the consequence would be if some of those pressures were to change. Okay, so just know by definition some of these disorders and diseases of the kidney and the urinary system, as well as if you look at table 26.2, page 337 in your lab manual, the kind of disorders of urine and some of the atypical things that you can find within urine. All right, so no examples of those. I'll give you a description, definition, whatever, and you know choose the disorder disease. Okay, so just know a few of these for the practical as well.